work. The last weeks have been on school-based, adolescent, counseling, and today we're going to focus specifically on how SUD treatment differs through telehealth, talking about both clinical as well as medical treatment of SUD. And then we'll also talk a little bit about recovery considerations for telehealth, because I think it's important that you're aware of some changes in that as well. And next slide. So briefly, I am native Nebraskan, but actually was born in South Dakota. So I have a lot of interest in the area. I live in Colorado now, in Denver. I'm an avid rower. Down on the bottom, that's not me. That's me on the top right. I'm an Aries. And I also am a physician, and I do substance use population health. So I do a lot of administrative and regulatory and funding help for organizations, all of them publicly funded and serving low-income populations like health centers on substance use. So I keep up with all the changes on telehealth during COVID and outside of COVID, and just general best practices on how people are treating substance use, both online and offline. Next slide. Oh, and that's supposed to be an MD. It's not MN. It's MD, MPH on the last slide, just so we're clear. So these are learning objectives. Talk a little bit about how tele-SUD differs from in-person treatment, because there's some big differences, but also some big similarities. Second, we'll talk about the COVID-related changes, which actually some of those are now maybe starting to change back as COVID, not that COVID is fading, but in the next few months, some of those will probably change back. Third one, we'll talk about virtual recovery services. So what's going on parallel to telehealth and telemed in the recovery world, and then the best practices that I've gathered over the last 8 or 9 months of COVID-related tele-SUD treatment. And we'll have plenty of time for questions too. So if you have any questions, feel free to either break in or to ask them in the chat. Next slide. So what's different about tele-SUD therapy? For people out there who are doing counseling online, individual counseling, tele-SUD really not all that different. I think the primary difficulty really is, and I forgot to mention, I'm also in recovery too. So I've been in recovery for about 6.5 years. So I know this both from professional expertise, also from a personal standpoint of having undergone SUD treatment and even tele-SUD treatment, and having seen what's worked well and what has not worked well. So I think the primary difficulty in really a lot of individual therapy, mental health and SUD situations is that your client is, their condition is not visible, right? That's why mental health is stigmatized. That's why SUD is stigmatized, because you can't see the evident symptoms and how much someone is, often hurting inside from substance use. And so, that's not really that different whether you're meeting with somebody online or in person. Like, this is still a hidden stigmatized condition that they're not always forthcoming about. And I think there's definitely some things you miss out on the online format, right? If somebody smells like alcohol, that doesn't come across yet in teletherapy, although I'm sure at some point we will be able to smell and engage in all the senses of teletreatment, for good or for bad. And probably a little bit more difficult to see signs of intoxication or withdrawal, lines under the eyes, nodding off, things like that. It just can be a little bit more difficult through the video. And certainly if you're providing telephone therapy, which, I know a lot of you are in pretty rural areas where connections are not great. A lot of these things are much more difficult through the telephone, if not impossible. But I think that rapport building is still pretty similar through a good video connection as it is individual. Like, I've been pretty happy with individual sessions from a patient standpoint through teletherapy. There's obvious technology hiccups, but I also think that you have to think about, comparing that to in-person, there are probably many more technology or transportation hiccups, traffic, people not having a car, not being able to get to the place. That the technology hiccups are actually not as bad as those, in my opinion. So I think that's an important thing, is to have a really robust technology platform and also a good onboarding procedure for your clients, because a lot of them, I think probably most of the professionals on here have been using Zoom at least for several hours a day for the last 9 months. And some of you are probably using it several hours a day before that. Clients haven't always been doing that. And so you need to have really good online onboarding where, you're spending part of your first session just dealing with the technology, helping people to maybe sync their telephone with their video. So if their video doesn't work, their telephone is seamless. I still do that for meetings if I don't think I'm going to have a good connection. But anyway, I think individual is a little different, but it's still kind of the same. Like you're trying to build a rapport with someone. And next slide. For group, it's a little bit different, right? Group, you're really, at least the groups I've been in, the therapist is important, but you're really learning primarily from other members of the group, right? And so building that camaraderie over weeks, over long term with those people is really the primary difficulty. So the focus, at least for me in groups, is shifted from the therapist-client relationship to camaraderie and fellowship amongst the members of the group and trust, right? There's some inherent trust in a therapist. You don't have that automatically with other people in a group. And so how many people out there are doing groups online? I guess I should ask that to see how relevant this is. If anybody can put that in the chat, thumbs up, thumbs down. I just want to get an idea for how much to focus on group versus individual. You are, yes. Okay, so the first couple of people are, and that's great. I think that not doing, okay, so some yeses, no, some no's. No, mostly no's. Okay, I'll focus about half and half. Thank you. I think that's a big favor to people, and I know it depends on your reimbursement policies also. Like in Colorado, as we'll go over later, we've been pretty lucky in that most reimbursement policies have opened up to group therapy, but I know that not all states have done that, where ILP or groups sometimes aren't reimbursable online. But like I said, I think the main difference in group is that you're learning from your fellow people in treatment, right? Whether those professionals, other people with criminal justice involvement, you have some factor that puts you in the same room, but you don't feel that same shared camaraderie with people off the bat. In fact, often there's mistrust of people. You're not anonymous in these settings. You can't guarantee that your information is going to be confidential. So it's a lot different until there might be other people in the room, right? You don't know. Unlike in person where everyone who's in the room, you have some trust that nobody's recording it. You don't have those things in groups. So that's a lot more difficult, and I think requires a lot more upfront camaraderie and trust building for online, for virtual SUD treatment for groups. And I mean, the big, maybe even bigger than that lack of trust or needed to build trust is the technology programs, right? I can be somewhat certain that my therapist and I are going to have good technology and be able to talk or at least call each other. The chances of somebody having technology problems in online SUD group are 100%. Like somebody is going to have connectivity problems. They're going to have trouble using the Zoom interface. And so that's such a big deal in group where it can really ruin a session. And I take this mostly from like 12-step groups. That's the groups that I have attended since COVID. And it's just ever present. There is always somebody whose audio doesn't work. There's somebody who's picking up their kid and they're driving around in their car and they're still on video. And so that's almost worth, a partial session just to set really robust ground rules for people. So I think that's something, if you're not doing this already or you're considering it, or if you're doing it and you haven't dealt with this, I'm sure you have dealt with it, that you set your policies about like what people can be doing, where can they be in order to participate in group, because I can tell you it's really distracting to have kids crying in the background. It's really distracting to be driving, which is a really common one I see. And it also doesn't guarantee other people's anonymity or confidentiality, right? If you are in a public setting. And so that's really important. But also, the group, is really distractible when somebody's having technology problems. So I think there's a lot more differences with group than with individual when you move from in-person to a virtual setting. Next slide. And I think go back one slide. I think, one thing as you move to virtual is, like, for people with really severe substance use disorders, often they might be experiencing thought disorders as well, caused by their substance or by withdrawal. And that's very much exacerbated, like online exacerbates that. So people have, often thought disorders consist of bizarre beliefs about technology, the internet, TV and things like that. And so I think, I can say from when I was early in treatment, I would not have trusted somebody through a video link, like especially somebody I hadn't met yet. So that makes it really difficult, I think, for somebody who's in early substance use treatment, that they may be having a substance-induced mood or a psychotic disorder. So keep that in mind. I realize that not all services are available everywhere, but for some people, a crisis center or a residential setting, if those are available, may be the only appropriate place for them to be treated, because if it's a lot easier, obviously, in teletherapy to depersonalize, even if there's somebody right in front of you, to think that they are not a real person or that they don't have your best interest at heart is, it's much more viable over tele. And I can tell you, like, being in front of somebody in acute withdrawal, like, just to have their warm heart there and someone speaking directly to you is really important. And so this might be, if you're doing some in person and some virtual, this is definitely a setting of acute withdrawal or really serious substance use disorder to make an exception and see somebody in person, or again, to consider a higher level of care if you have that available in your region. Next slide. So this is more for the administrative folks out there. There have been huge changes in the administrative and regulatory realms around COVID. Some of those specific to substance use and some of them more general about telehealth. Obviously, the big one is that almost all payers, at least in the spring, who didn't allow telehealth before, telemed, do allow it now. And I think most places had some provision for telehealth, but it wasn't always comprehensive. And that's relaxed in almost all settings that I've found: commercial, Medicaid, other third-party payers. Virtually all of them allow at least some telemedicine or some telehealth, telecounseling. But this varies widely by state. Some places only allow video. Some places allow telephone. I think in Colorado, you can do telephone, but that's only during the COVID emergency. That otherwise it has to be video, synchronous video. So that's something that, again, varies by state, and I'm not familiar with North Dakota, South Dakota's requirements. But those are also, as we'll see in a couple of pages, I think some of these things are going to start becoming more stringent after people start getting vaccinated and moving toward going back on some of these. I think some will stay, but some will go back. And the reason for that, if there are any people from payer groups out there, is that despite there being less appointments, at least early in the pandemic, there were less mental health and substance use appointments being made just because people were sheltering in place. The show rate is a lot higher for telehealth. So people don't miss telehealth appointments as frequently, or at least that's been what most of my clients and people who work in Colorado have found, is that people tend to show up. And so actually some of our behavioral health organizations have equal to higher visit rates actually during COVID pandemic, because people don't have to catch the bus. They don't have to rely on their friend for transportation. And also they can, do something that's somewhat uncomfortable from the comfort of their own home. And so the show rates have been really off the charts for, at least in publicly funded behavioral health care. So that's unfortunately one reason why payers are not as excited about this, because especially for capitated payers, they're paying out a lot more. And particularly if any of you run IOPs, one organization I work with, used to run IOPs mostly for justice involved people, and they would get, their show rate was a third, 30%. And so they'd have an IOP with 15 people and they'd get 4 people. Now they get 10 or more at a lot of their IOPs. So, well, that's really good for them and good for the group to have some regularity. It can also be, it's expensive for a payer to pay $100 plus per session IOP and have everybody show up. So the second one, OBOT. So this is a Suboxone, provider of Suboxone. So a family doctor who provides Suboxone, or a place that does more specific addiction treatment, but prescribes buprenorphine, Suboxone. And I'll use buprenorphine from now on, but I say Suboxone just so that we're on the same page. And I'm really referring to any form of oral buprenorphine. So whether it's a combination with naloxone or whether it's just buprenorphine. The big difference here was that they have waived some provisions of the Ryan-Haidt Act. Previously, you had to see somebody in person in order to prescribe them buprenorphine, and now that's not the case anymore. So you can prescribe buprenorphine on the first visit without a physical exam. And so that's a big difference, and it's been really beneficial for people during the pandemic who can't make it into a clinic or when clinics were closed down. And we actually have some places that are doing that kind of, it's certainly still pandemic time, but they're planning on doing that after the pandemic ends. For instance, if somebody goes to an emergency room, gets treated with buprenorphine, and then has a wait before they can see someone as an outpatient, there are some teleclinics that will prescribe them a few days worth of buprenorphine. And so this is a big change. This is actually something that was going to happen. The DEA has been saying for about a year that they were going to make this change, but they hadn't made it until March. And it's still a temporary order, but I think this is one that may continue. So you may continue to be able to prescribe controlled substances. And I think it's, I don't know if it's all controlled substances or if it's just for treatment, but I know that buprenorphine can be prescribed through teletherapy on the first visit. So OTPs, I know there are not a lot of OTPs are methadone clinics, opioid treatment programs. I know there's not a lot of methadone clinics in South Dakota and North Dakota. I think last time I checked, there were 4 or 5 between the two states. But they have a lot of differences. For instance, they can do longer takeaways. So that's when people don't have to go every day to get their methadone or their buprenorphine, because they treat people with that as well. There are a lot more exemptions to the rules. So these are very rule-laden organizations. And the DEA has given a lot of exemptions to, like I said, give people an extra day of dosing, to dose people in their car. So previously you had to go in, there are cameras everywhere. Now sometimes, especially for people who are at risk for COVID, they'll dose in their car. And they can do buprenorphine without a physical, kind of like the OBOTs do. So a lot of changes around methadone clinics. The one thing that they have not changed is that you can't start people on methadone without a physical exam. So that's still a must for people who are going to get methadone. So if you have somebody who can't make it in for whatever reason, they have acute COVID or something, buprenorphine is probably a better choice, just because you can prescribe it without seeing them in person and doing a physical exam. Then the big change for community health centers, federally qualified health centers, is that telemed generally wasn't a billable service before, and now it is. So huge change. I know our community health centers in Colorado have jumped in on telehealth really, really heavily, and all of them offer it now. A lot of services through telehealth. Next slide. Okay. And again, this is Colorado, because different states have different rules, and I can't keep up with all of them. But in Colorado, groups are allowed, and including intensive outpatient. So that's been, as I said, a huge boon for clients, really kind of a boon for behavioral health organizations, more difficult for payers. And I think going back to the group therapy page, I think the difference is here, it depends on what kind of group you run. Some people run closed groups where everyone starts at the same time, kind of allowing you to build a rapport with the other people in the group. I know that that's not always feasible given your population, but I think that's really more important during COVID and during tele is that you have groups that have some continuity and longevity to them, so that people really get to build trust in other people in the groups, and so that you don't have people coming and going every week. Michaela, can you reshare the presentation? Yes, thank you. So a lot of states also have made licenses transferable, whereas before you had to get a license in every state you practiced in. Many states, and in fact, I think when I checked, it was most states allowed you to work across state lines. And this was in response to people being, disrupted from work or having shortages when there's high demand for substance use treatment services. So again, you have to check this. There are some good websites. I think one is through Manatt, M-A-N-A-T-T, a law firm, and they've cataloged all the different COVID-related changes. But this one, I know that as long as there's an emergency, the licenses are transferable. And some of them you don't even have to apply. You can just use your New Hampshire license in Colorado, as long as you're a licensed clinician. I think for medical, they have a more rapid approval of licenses, but they don't automatically transfer. And then HIPAA compliance was suspended. Again, this was important, I think, in the first days when people were really just scrambling to pick things up. I don't think nobody that I'm aware of is using HIPAA, not HIPAA compliant platforms now for telehealth. That would not be recommended. And most places now have a platform. I think that was the big difference, is that before there was no platform and people were just scrambling to choose one and to, get signed up with ZocDoc or Zoom or whatever they chose. So this is still in force, that the HIPAA compliance is suspended, but it's not a good idea to use non-compliant platforms if you don't have to. And then 42 CFR, which probably applies to some of you that are specialty addiction treatment providers, is always suspended in emergency situations, but they don't give you guidance about what the emergency is. So for people who aren't familiar with this, 42 CFR is essentially kind of an additional layer above HIPAA for substance use treatment organizations. So that's not everybody who provides substance use treatment is a substance use treatment organization. It pretty much means that you do a lot or the majority of your business in substance use treatment. So this would not apply to family doctors or federally qualified health centers for the most part that just have a buprenorphine prescribing program. It's really for residential rehabs, places that advertise themselves as substance use treatment providers. But like I said, this is definitely something to consult a lawyer about if you aren't sure if you're covered by 42 CFR, or if you're considering being in violation of 42 CFR, even in an emergency situation. That is the roundup of administrative and regulatory changes due to COVID. Next slide. And I think that the big change here is already when things were kind of seeming to cool off in August or September. I know a lot of the payers here were discussing making some of those changes in reverse. So not paying for intensive outpatient, not paying for groups. And so I think those will be some of the first changes to go back to what it was like before. And so just keep your eye out for that. Your state Medicaid organization or your community health organization are on top of that, I'm sure. But be aware that these are probably going to start changing back in the spring, I would say, is when vaccination starts to become widespread. And so note all those things that we just talked about, the privacy laws, the payers, the federal guidance on whether you can prescribe to someone for the first time through telehealth, many of them are going to change back. I think that there will still be a general loosening from pre-pandemic, but a lot of things are going to go back. So be aware of what's going on in your area around substance use services, because they are often being driven by payers or federal guidance. Okay, so that's about the halfway point. Is there anyone that had questions on regulatory and payment, or on some of the, from a patient's perspective, some of the clinical differences in teletherapy and telemedicine? Feel free to unmute yourself and ask questions if you like, or to put them in the chat. Okay. We'll move on, and there will be another time for questions at about 10 till. So next slide. Okay. So this is really important. It's a little bit outside of telemedicine, but I also think that, one of my big thrusts as a public health and a practitioner of like systems level work is how back one, I think. Wait, maybe that's, oh, no, you were right. You're right, next one. Two of the big things I think are make sure that we get out of our silos, right? Generally substance use treatment is unified, right? Substance use disorders are one entity, and the substance of choice for people really has more to do with who they hang out with, what kind of things they have access to, maybe some genetics, but I really believe in substance use disorder as a unified thing. The other thing that I think of as unified that we treat as very different are treatment and recovery, right? Treatment usually consisting of billable clinical or medical services, and recovery consisting of honestly far more nebulous group of peer delivered or community-based services. And that's, I think, that's the hard thing about recovery is just defining what it is, because it really is just goes from a pretty well-defined set of services like sponsorship and going to 12-step meetings and meeting with a peer recovery coach to just life. And so that's just one of the hard things about saying what is recovery. But let's see. Okay. So before COVID, I recommend that people who are dealing with people with substance use disorder on a frequent basis have kind of a go-to 12-step meeting. And again, I know some of you are in pretty rural communities. Most, even very rural communities, have an AA meeting. It might only be once a week, but AA is pretty widespread, even in small towns. And so I would, even during COVID, go to your local AA website, or if you're in a larger town, you may have other 12-step groups, and I would encourage you to explore which 12-step groups you have available in your area, and try to have a go-to meeting, maybe even one that you've gone to and introduced yourself as a clinician or as a medical professional, and really checked out, because meetings vary dramatically. And now the hard part about this is that a lot of these meetings are now online. I would say, at least in Denver metro area, probably at least 90% of meetings ended their in-person meetings, at least temporarily, and most of them are still not meeting in person. And so it's important that you have this for when the pandemic ends, that you have a go-to meeting, but that's a lot harder now. And I don't expect clinicians or prescribers to keep up on this, to check and see which meetings are open. So that's a little bit beyond your purview. So I think that just being able to refer people to the online versions, and know that there are a lot of online meetings, right? And maybe even if you know that there's one meeting still in person in your area and you feel comfortable referring people to it, I think it's really important, particularly for people in recovery, right? The in-person component, in fact, there's good evidence for 12-step groups. If you haven't read it, the Cochrane Review summarizes the evidence for 12-step groups. They're actually pretty effective. They're almost as well, they're about as effective as therapy, cognitive behavioral therapy with a professional. And so a lot of that is due to the fellowship. So when they look at the mechanism of why 12-step group work, it's about being with people who share a condition and some experiences. And so the in-person part of that is really important, I think, particularly for people who are newer in recovery. So I do think it's important that if somebody is interested in that you have hopefully a local resource where they can go to a meeting. And that, like I said, the sponsor and the community, really the fellowship, are the magic. The steps really aren't they found like the magic. So what fellowship you refer people to is, I think, in my opinion, less important than the fact that there is a regular group of people who are in recovery who are meeting together. And so whatever you have in your community that matches that, that's great. And sometimes that's not even a meeting, right? We'll go over on the next page. There are recovery gyms. There are non-recovery-based fellowships, men's groups, women's groups that are really helpful for people. And I have a question on what was the name of that study or writers on effectiveness of 12-step groups? Give me a second. I'll look it up really quick. But I think if you look this up, you'll find it pretty quickly. It's Cochrane Review, and I don't usually like to use the fellowship name, but they specifically review AA. I think you'll find it pretty readily if you look that up. So Cochrane Review looks at all the studies that have studied anything, and I think a year ago they put out a new study that said pretty definitively that 12-step groups work for people. Because for a long time there was a misconception that 12-step groups were voodoo and they really were a placebo effect. This shows that they're pretty helpful for people. And so, normally I'm not a huge fan of apps. I'm still not a huge fan of apps, honestly. And so I haven't found the killer app. There are many apps out there that offer peer support, coaching with certified coaches. Some of them are pretty expensive. And like I said, I don't know to recommend one over the other. But one thing that I would do is look at cheaper and free options through your local recovery community organizations. And you can find this. What is your local recovery community organization? This is a really good thing, especially during the pandemic, to familiarize yourself with. And I think I looked this up earlier, and I think there were some in the Dakotas. I'm actually looking it up right now. Okay, so the Faces and Voices of Recovery is a great organization, and it is essentially the clearinghouse for professional lay recovery. So it's non-12-step based recovery. Oh no, and actually there are no recovery community organizations in North Dakota or South Dakota. So I'm really sorry. But you probably have something like this in some of the larger communities. It's like an advocacy organization for people who are in recovery. And a lot of them offer peer recovery coaching through their organizations, or they have a list of volunteers that offer peer recovery support. And so this is an even better resource during COVID, because a lot of these people, will work through phone, or people can meet one-on-one for coffee. So they're not meeting in a larger group setting. That is really, really, really important. And it's a great adjunct to formal treatment. Obviously, I'm not recommending this as a substitute for formal treatment, but it's a nice adjunct. And I think here, this brings up the importance of certification or credentialing. This is definitely in its infancy, the certification or credentialing process for peer recovery specialists. But making sure that somebody is meeting with a credentialed or certified peer is really important. And some of these apps or some of the advocacy organizations can offer this to make sure that they're getting non-judgmental, unbiased peer recovery support. So summary on this one, I think that it would be nice if you had an online 12-step meeting that you trusted, and then you could refer people specifically to that, because I like for people to have a specific meeting to refer to. It's a little more difficult during COVID because you don't know who's going to show up to online meetings. Like people from India show up to online meetings, or people from Serbia, and that's really great, but it also creates a lot more variety in who's there and less of a consistent fellowship. So it's difficult, but if you can have one of those that, again, maybe you attend it, or maybe somebody that you trust attends it, I think that's really, really helpful. And then check in with your client on what they're doing. Like, treat it like a medication. Did you go to that meeting last week? Why not? Did you not like it? Okay, here's a different one. I'd like you to try this. And then also looking more into recovery coaching during COVID, I think is important, just because there's less opportunities to meet people organically that would serve as a sponsor or a recovery coach. Next slide. So some of this duplicates what I said in the last one, but The nice thing about those 90% of meetings that I said in Colorado were canceled, I would guess 90% of those switch to an online format, almost always through Zoom platform. So there has been an explosion, much like there's been an explosion in telehealth and telemedicine. There's been a similar explosion in telerecovery, in that, like I said, almost every meeting now meets online with the same regularity and at the same time. And it's kind of cool. People can explore and they can go to a meeting with their friend in California or in another country. And so it's kind of nice to have more options. They can also have a lot greater anonymity, right? Because some people are afraid to go to their local 12-step group meeting because, the car will be seen outside, or someone will see them there and recognize them and perhaps violate their confidentiality or their anonymity. In this case, you can purposely go to an out-of-state meeting for that reason, right? So that you're not seeing people from your community. And so some people really like that. The downside here is there's less chance to socialize. A big part of the meeting is talking to people before and after the meeting. And this doesn't always provide that, although some of the 12-step groups allow people to stay afterwards and just kind of chat amongst themselves, like socialization. And I think the big thing here is, when I say 12-step, I think a lot of us think of AA just because it is the predominant fellowship as far as numbers. Especially some places in the Dakotas, there's you probably have some NA, Narcotics Anonymous meetings, maybe some CMA or crystal meth anonymous meetings, but there's probably not a lot of other fellowships. That's true in almost all states. But I think the difference here is that you can go to a CMA meeting if you live in Wahpeton, but you just go to a CMA meeting that's technically held somewhere else. And so for people who really want to go to a specific fellowship, but maybe can't because it's not offered in their area, this explosion in telerecovery has actually been really great, because people can now go to this specific fellowship. They can go to non-12-step fellowships. They can go to Smart Recovery. They can go to LifeRing. Nice, intherooms.com. Thank you for mentioning that. That's definitely the best resource for meetings. And I think it acts as a clearinghouse for all types of online recovery meetings. So that's good. That was good before COVID, but obviously there's a lot more options now. Most of the individual fellowships now also have a similar website where they list their online meetings nationally and internationally too. But yeah, you're right. In the rooms, I don't know this, but my guess is that they probably have some links to peer support too. That's a really good website. Thank you for bringing that up, Kate. Next slide. So one thing, this has kind of been a bright spot, and this has to do with recovery community organizations, which, like I said, there are not as many in the Dakotas. You probably have some advocacy organizations, but I found that a lot of these less formal supports for people in recovery are continuing to meet in person, obviously mostly adhering to guidelines. But I think the key to these is that they're really based in person and, treat substance use disorder as the deadly disease that it is, that isolation has for many people been deadly. Overdoses are up, I think, about 40% nationally during COVID. And so, obviously I recommend people adhere to all COVID-related guidelines, mask wearing, gatherings, but it is really important that people feel fellowship and feel supported, whether they find that online or in person. And I know that some of our recovery gyms, even some small towns like Steamboat Springs has a recovery gym, they're continuing 5-day-a-week in-person programming with social distancing and often outdoors when they're able to do it. So if you have an organization like this in your area, they may still be doing in-person services. And I would encourage you, if you have an advocacy organization or a fellowship, sometimes they're based through a church, these can be really, really beneficial for people to get plugged into a group of people who live in the same area as them. Next slide. So the best tips for tele, these are more technical that I've heard since COVID. There's 2 of these that I learned from other people, and then there's one that I've kind of developed, particularly around recovery on the last page. So by now, you probably, if you're going to develop telehealth or telecounseling, you probably have. And so I think that's, you know, in the early days, this was really important just to like think of this as long-term. And it's proven to be pretty long-term, not pretty long-term. Also be aware that there's more than just like, I always liken tele to in-person because there are many more ways than what you think of at first to utilize it, right? So you think about like, okay, I'm going to counsel you, but there are a lot of things, almost anything you can do in person, you can do through tele. Like you can supervise through telehealth. You can train people through telehealth. You can monitor the fidelity of their therapy through telehealth. You can do visitation. This was one of the creative ones I saw, is that a lot of residential facilities or you know, other 24-hour facilities like sober livings are not allowing in-person visitation just to keep a bubble. But you can have visitation. You can have times where people meet with their friends or their family, or have a speaker come and talk to them while they're in residential or they're in detox. If there's anybody that works in a residential or recovery resident setting out there. Use a VPN if you're working with clients from home so they can't figure out your IP address. I think that that's a way, something I never would have thought of. I'm not a tech person, but I think this is a really good idea to maintain your personal confidence. The Phoenix, nice. So the Phoenix is actually the organization I was talking about in Steamboat Springs. It's a recovery gym, and they are doing a lot of online programming, and they've opened it up to people all over the country. So this is a great resource for anybody that needs more recovery referrals for your clients. And then the last two on here, virtual backgrounds kind of provide anonymity. Although I think people seem to be moving away from virtual backgrounds. Actually, after early in COVID, people were all about virtual backgrounds, and more people just use their natural background now. And make sure your liability covers telehealth. Most of them do, but not all of them. Next slide. Okay, we talked a little bit about this earlier. Make sure that you're getting appropriate clients for telehealth, and these are some of the conditions that would be less appropriate for telehealth. And I added to this earlier, you know, really severe SUD, and that's kind of covered under withdrawal potential, but probably not the best clients to start on teletherapy. And then obviously internet addictions, not good. Attend to technology, take 10 or 15 minutes at the beginning of your session and just set it aside. I know that's not billable time to talk about technology, but it will behoove you for the long term. Safety plan, make sure you have a phone number. If somebody's internet goes out, then you can continue this via phone. And one thing that I have found really, really helpful is I make my facial expressions a lot bigger when I'm talking with somebody on video, just so it's more evident the emotions that I'm expressing. So they can see empathy, they can see happy, sad, because again, it is a little bit, there's a lot lost in translation, even over a good video call. And so that's something, I actually am really tired at the end of the day after calls because I feel like I'm emoting a lot more than I normally would in person. And next slide. This is my last slide. So particularly for group, like, and this is even true in one-on-ones, people tend to talk over each other. There's a lot of memes I'm sure you've seen of people like talking over each other on Zoom, and that's exacerbated by the slight lag that you get for video calls sometimes. So I think particularly in group, it can be helpful to set either time limits or have people raise hands. That's something I've seen on both of these actually in recovery meetings, where they're pretty aggressive about keeping people to 3 or 5 minutes, or having people raise their hand. So you can raise your hand through Zoom, or sometimes people will just physically raise their hand. I actually find that a little bit easier, so that you know who wants to go next. So there's not that stepping over each other. Video on whenever possible. It's particularly in recovery meetings, it's really demoralizing to speak to just a screen of names, of first names. And so I really encourage you, especially in treatment settings, to have people have their video on whenever possible, because that helps to build that trust, understand that there aren't people, at least in the immediate vicinity of other people in the group, And definitely an individual, this is really helpful. And then the last one, again, this is another thing that you can do more easily actually online. There are some things that are even better online. If therapy is in tandem with medication, so if somebody's taking mental health or substance use medications, you could ask them to either see them online, like, hey, could I see how many of your buprenorphine strips you have left, or to take it online if they have trouble with adherence. So again, you can do that in person, but it's an additional step that somebody has to remember to bring their medications. So I think that this is just one example of, like, you will think of cool things that you can do online that you can't do in person, and that always makes me feel a little hope for the future, that we're not just headed for a world of like online facelessness, that we will actually figure out ways to make things more robust and multidimensional, like using chat while someone's presenting is kind of cool, and it gives you a way for people to communicate outside of the lecture situation. So if I can end on a hopeful note, that's it. That we will continue to make platforms more robust and figure out ways to make teletherapy and telemedicine even more helpful for clients, and more bearable for the therapist or the doctor. So that's I think that's my last content slide, and so I will open it up for questions now. And next slide. Yeah. And feel free to contact me if you have any questions about anything I said today. I am happy to answer them. But for now, I will open it up to any questions if you want to unmute yourself and ask a question, or to ask questions through the chat. Okay. So the Cochrane review, it is by Kelly, JF Kelly, and it's called Alcoholics Anonymous and Other 12-Step Programs for Alcohol Use Disorder. And that's the most recent version of the Cochrane library. And I think you get full text for free through the Cochrane library. So you don't need to have or at least you get a pretty good summary through just with publicly available access. So you don't need to have a fancy subscription to a research journal database to read this.
Hey JK, it's me, Thomasine.
Hey.
Glad to queue up a question here. As we've been rolling out a lot of telehealth training since March, what do you think has changed in terms of providers' perceptions of telehealth from March until going into the new year in 2021? What have been the big shifts that you've seen, if any?
The big shifts I've seen throughout the year, I think this is true with all kinds of teleservices in March. People were really enthusiastic, and I can tell you, I went to like more 12-step meetings than I normally do in person, and that lasted about a month. And then I'm so sick of it. I would not go to another online 12-step meeting unless things completely shut down in person. And even then, I would minimize it. So I think there's therapists and doctors have done the same. Like they're just sick of being online. And so one of the best hints I had about this was that you can only do about half as much tele as you would do in person. And I think that's probably true. A lot of clinicians limit their time online, which I think is really healthy, actually. And so if you're running a larger organization, to have a rotation of people who are doing in person, most places, at least in Colorado, have gone back to, they have a mix of in person and online. I think if I were a clinician, if I were prescribing, I would have some set aside time, maybe 2 or 3 hours a day that I did tele, and then the rest of the time set aside for in-person visits, rather than dedicating people to tele and having tele specialists. I would definitely not do that. Like you just get burned out so fast. I think that's one big thing, is just recognizing that it is harder to focus online, and you get sick of looking at a screen, and there's blue light and stuff like that. I'd say the other big change I found is, this sounds weird saying it after that, but it's like how much people like it because they can work from home. I mean, you can work not just from home, you can work on vacation. And so people, generally providers have a almost unanimously positive view of online work as long as they're not doing it too much. And so that's been really beneficial and kind of a pleasant surprise and clients too. I mean, like I said, the biggest surprise that I don't think anyone saw coming was how this would increase access. And I realized that it's not necessarily true for everyone. Broadband, again, is not available. Definitely in a lot of areas of Colorado, broadband access is lacking. But it has improved access. I would say nobody's access has gotten worse really during COVID, or I should hedge on that. Most people's access has not gotten worse, and many people's has improved. People with kids, people with mobility issues are much more able to attend therapy and recovery meetings than they were before. So I think that's been it was foreseeable, but nobody really thought about that like, hey, if we did telehealth, it would be, it would increase access even in cities. I guess I thought about telehealth as a rural thing, but really having to drive across Denver, that's a long trip. That's an hour trip to go back and forth in no traffic. And so to be able to save that and give that back to people to spend with their family or to work if they're able to work from home is a huge benefit. Other questions? Okay. So we've got 4 minutes left, and I'll show you my favorite thing for stigma. So this is called the addiction tree. I'm just going to share my screen here. If you have issues with stigma, which I assume that everyone does, this is the most powerful resource I have found really anywhere to help dispel that. And so this is not my favorite version of it, but it's a pretty good one. Oh, here it is. And so I use this in most of my presentations. And here you can see it a little bit better, I think. So this really helps people who don't understand addiction, or why people get addicted, to understand that the manifestations that we find most difficult to deal with or most odious, drug use disorders, compulsive gambling, and even more socially acceptable vices like obsessive thinking and perfectionism are really born out of, a very long history of often trauma, other things down here, genetics, other ACEs are really the roots of, I think all addictions, smartphone overuse, relationship addictions. Like I said, people develop those because something bad has happened to them, and that you don't see that bad part. So when people see this, I use this a lot in criminal justice settings, and everybody understands it, that, oh, I'm only seeing the leaves, right? I'm only seeing the branches of the addiction, and I'm not seeing what's going on inside people. And it also helps people understand that, like, it takes a long time to get to the roots, right? And so it takes, can take years of counseling, medication, to really get at the roots and help people understand the ACEs and other things that have caused addictions. And so it's just such a good metaphor for anything. And you can look it up. There's a few versions online. You can make your own based on, how you see this working for your clients. But like I said, well, no one is asking a question, I wanted to put out some high yield stuff. And this is the best thing I've seen in a long time. Okay. If there are any last minute questions, feel free to ask them. Otherwise, I will hand it back to Michaela.
Thank you so much for your presentation. I know I learned a lot from it. If you guys have, oh, it looks like we do have a question. Oh, never mind, that's a clapping. We will be sending out an evaluation that we ask for you guys all to put out or to respond to for them at the ATTC, correct? And yeah, so we will thank you all for coming, and we will sign out then today.
Thanks for having me, everyone.